Welcome to our webinar, Hormones and the Basics of 24-Hour Urinalysis. Today our speaker will be Dr. Krista Hinchcliffe, who received her naturopathic doctorate degree from Bastyr University. Previously, she studied pre-med at Evergreen State College. Beside her scholastic achievements, she has studied closely with Dr. Jonathan Wright and other practitioners at Tahoma Clinic. At the clinic, Dr. Hinchcliffe practices general medicine with an emphasis on women's and children's health issues, including bioidentical natural hormone therapy, gastrointestinal disorders, osteoporosis, thyroid problems, chronic fatigue, ADHD, and chronic disease. Dr. Hinchcliffe is the clinic's focal doctor for Dr. Wright's well-known bioidentical hormone treatment for women, a natural alternative to traditional hormone replacement therapy. And now, to introduce Dr. Krista Hinchcliffe. Thank you.
Good afternoon. This is Krista Hinchcliffe from Meridian Valley Lab. Thank you so much for everyone joining today. I want to make sure everybody can hear me okay. If you're having trouble, please do type in and let me know. I'm watching the reader board here to make sure that if anybody has any questions or concerns that I'm able to get to those as soon as I can. As far as questions, I will try to answer questions as we're going along. If it seems as though the question applies to one of the slides that we will be going over through the presentation, then I may wait. But if you do have a question, please feel free to type it in and I will get to it as soon as I can. So today we're going to be talking about hormones and the basics of 24-hour urine testing. It looks like from the answers that you've given that most people here are using some form of bioidentical hormone replacement therapy, but there are some new people to bioidentical hormone replacement therapy as well. And as far as urine testing, most people have not used the urine testing that are listening today, but there are a couple people who have. So I'm hoping that the information that you gather today will be well equipped for people who are starting, as well as gaining some new information for people who have been doing the hormone replacement therapy and using the urine testing. So again, just let me know if you have any questions. I've been working at the Tahoma Clinic with Dr. Wright since 2002, so I've been there almost 10 years, about 9 years now, and have been using the bioidentical hormones for every one of those years that I've been there or have been there, and feel really good about using it, feel good about the safety of the hormones and the success that I've gotten with the hormones. And using the 24-hour urine testing has been extremely helpful in managing people's dosing and feeling good about the safety. The 24-hour urine testing gives so many different analytes that we can look at. Just gives us so much information about how the body is actually metabolizing the hormones and what the body does even without the hormones so that we can be more successful with what we're doing. So as you know, there's different ways to actually look at steroids. You can use serum, which is a really common way, and most of the time I think that's what most practitioners will use. There's also saliva testing, which quite a few people use as well. And then there is the urine testing, primarily 24-hour urine collections. And today we will be focusing on the urine testing, as that is the gold standard for testing for steroid hormones. And I just wanted you to know a little bit about the difference between what you're seeing in the urine versus what you see in the serum or the saliva. When you look at the urine, it actually measures the sum of free and conjugated, or sulfated and glucuronidated hormonal steroids, so meaning the free or the active hormones that are not bound to any protein or carrier, as well as hormones that have been conjugated when they've gone through phase 2 of the liver pathway. When you look in the serum, what you're finding is actually the protein-bound hormones as well as the free hormone. And as you'll see as we go along, I do point out with some of the hormones that that's not very successful. For example, with estradiol, almost all of the estradiol that you see in the serum is protein-bound. So you're really not seeing that you have an active or free-form hormone when you're looking, or estradiol when you're looking in the serum. So you get more specificity or more information, again, from the urine test. It's definitely accurate for women and men, whether they're on or off bioidentical hormone replacement therapy. And a lot of peer-reviewed research on safety and metabolism of hormones is done with urine testing, specifically what we call GCMS testing. GCMS stands for gas chromatography mass spectrometry. It's a two-step process whereby the GC separates the sample into its constituent parts and the MS identifies the exact molecular structure of the compounds. And a quote here from a pretty recent journal in 2010 that states the gas chromatography mass spectrometry remains a preeminent discovery tool in clinical steroid investigations, even in the era of fast liquid chromatography tandem mass spectrometry. So a lot of big words, but I just wanted to bring this up because some labs do use this LCMS, and we actually do use that here for some of our serum testing for hormones. But for the urine, the GCMS still remains a gold standard tool for measuring the steroid hormones. As you see here, it remains the most powerful discovery tool for defining steroid disorder metabolomes, and it's a particular benefit of GCMS with its non-selective nature. A scanned run will actually contain every steroid excreted, providing an integrated picture of all the individual's metabolome. And a metabolome just means all of the metabolites of the different hormones that we're looking at, and we'll talk about some of those more specifically. According to Tietz's textbook of clinical chemistry, which is one of the textbooks that we use when we're learning about chemistry, he definitely talked about urinary assays being reflective of the secretory activity of the endocrine glands. And it's very reflective of the free forms of the hormones, as I mentioned earlier. One of the things that we find that's really great about the urine testing, it is a 24-hour urine test, so it's giving an average of the hormones throughout the day. As we know, the different hormones will spike and fall at different times during the day. So if you're getting a blood test or a saliva sample, you're only picking up on one of those times. With the exception of the cortisol, when you do a saliva test, it's really helpful on occasion to get the saliva testing done because it does give you the 4 different times throughout the day that you can measure cortisol, so you do get to see that pattern. However, with other hormones, we do prefer, again, to look at this 24-hour average, especially when people are using bioidentical hormones and they're looking postmenopausally because, or even premenopausally I should say, because the hormones have a certain half-life, so they're going to peak pretty quickly after they're applied or taken orally, and then they'll gradually decrease throughout the day. So again, 24-hour urine is great for that average. And if the lab is looking at the urinary creatinine, it also helps to make sure that the person is getting complete collection, and we do that here at Meridian Valley Lab. Many urinary hormones are conjugated to carrier proteins before excretion. We did talk about that. And so as a result, one of the things I just wanted to mention that you should always take into consideration when you're working with the urinary hormone testing is that you want to take into account the hepatic function as well as the renal function. And if there are any disorders with either of those organs, you may want to consider doing additional testing with serum or possibly even saliva, depending on what you are looking for. So the benefits, we already talked about how it's going to be capturing an average. But the other thing I wanted to really point out is a huge benefit with the urine test is when we look at estriol. Estriol is the weakest estrogen, but we consider it to be the most protective estrogen in the body, and it actually can help reduce breast cancer risk. There's been a lot of research by Dr. Lemon to help with discovering whether or not a woman has an increased risk of breast cancer based on her estriol level. If we look at estriol in the serum, we're seeing a very, very, very small percentage of the available estriol. Most of the estriol, actually 90%, is actually conjugated. And so looking in the serum, you actually won't actually see the conjugated form. It's not existent in the serum. You're only going to see that in the urine. So you do actually need to get a urine test if you're wanting to be able to test for estriol and see how well a person's estriol level is doing with the hormone replacement therapy or even without it. And then, as I talked about before, the exogenous hormones have the varied half-lives. So again, getting the 24-hour urine test can be really helpful. So here's just a slide that maybe you've seen before showing the different hormones and how they're metabolized, and we will go through quite a few of these. It all starts with cholesterol. We need cholesterol to be able to make all of these different hormones, and then it turns into pregnenolone, which is a master hormone, and then from there breaks down into all these other individual hormones. So steroids, there's different types, and they're grouped according to the receptors to which they bind. And actually, vitamin D derivatives are also a closely related hormone system with receptor sites, though technically sterols rather than steroids. But as we know, vitamin D does have very similar effects to steroids or sex steroids in the body. And I'm not going to go into detail about that, but I just wanted to bring that up. So there's different types of steroids that we're going to be talking about. There's the sexual hormones and the corticosteroids. The sex hormones are further divided into estrogens, progestogens, and androgens, and then the corticosteroids are further divided into glucocorticoids and mineralocorticoids. And here's just a pretty diagram to be able to look at that a little bit easier or to reference back to. So the estrogens, 97% in circulation are bound to plasma proteins, essentially making them biologically inactive. This is what I was talking about earlier, how when you're looking in the serum or in the blood, you are seeing that most of the estrogen that you're testing for is actually not free, it's actually bound, and so you're not seeing the active form, whereas if you're looking at the urine, you are seeing the free or the conjugated form. There's a lot of different kinds of estrogens, and they can be produced from progesterone, testosterone, and even DHEA. And then we have our androgens, specifically the DHEA, testosterone, dihydrotestosterone, 5-alpha and 5-beta androstenediol, androsterone, and etiocholanolone. Meridian Valley Lab actually has a new test that's not on the slide here that we won't be going into detail about because we're talking about urine testing today, but it does have a new test that looks at testosterone and its metabolites. It's done in the serum, and it's extremely helpful for those patients, especially male patients that you're working with, whose testosterone levels aren't really clear in the sense that you're giving them hormones, but maybe they're metabolizing them in a way that doesn't seem to be easily understood, and especially for those men who may be at risk for prostate cancer, who actually have prostate cancer. So definitely something to look at on the website. It's extremely informative, very helpful. And then you have your progestogens, so not progestins, but actually progestogens, which is a family that contains progesterone, pregnanediol, pregnenolone, and pregnanediol. Your corticosteroids, they're formed in the adrenal cortex and consist of cortisol, cortisone, aldosterone, and other metabolites of cortisol, cortisone, and androstenedione. So first we'll talk about estrogens in more detail. So estrone. This is a prominent estrogen in postmenopausal women. It interconverts with estradiol. Approximately 1 to 7% of the secreted androstenedione in males and females is converted to estrone, and a greater percentage if obese, because this conversion occurs mostly in the adipose tissue, and therefore obese postmenopausal women may have elevated levels of estrone. The estradiol is the primary estrogen produced before menopause. About 10 to 20 picograms per day is produced postmenopause, and 100 to 300 micrograms per day before. And this is from conversion from estrone in peripheral tissues as the person is postmenopausal. But premenopausal, of course, we're seeing it produced in the ovaries. When you're using estradiol orally as hormone replacement therapy, it's converted in the small bowel to estrone by the cytochrome P450 enzymes. And I just wanted to give a side note about oral estradiol. There is over a dozen studies that indicate that oral estradiol actually increases risk of stroke. So I highly recommend that none of your patients ever take oral estradiol. The topical estradiol by itself or even in the combination with Biest will actually reduce risk of clotting or stroke. So very, very important to look at. If you ever have a patient come in on oral, automatically switch them over to topical, and definitely use topical anytime you're starting anybody on estrogen. Even the sublingual estradiol, up to 50% of it can get swallowed, and therefore you'll still get that metabolism into estrone as well as get an increased risk of stroke. The estriol, it's produced in large quantities by the placenta during pregnancy, but it's also produced in substantial quantities in premenopausal women. It's the weakest estrogen with 20 to 30% lesser affinity for the estrogen receptor in the cell. It's anti-proliferative and immunomodulatory in its activity. It does convert to 2-methoxyestradiol, and we'll talk about the metabolites in a little bit. A large amount of estriol receptors are contained in the vaginal tissues, so applying it vaginally can be very successful, or even using vaginal suppositories of estriol can be extremely helpful for women who suffer from vaginal dryness. Most of the estriol is converted from estrone in the liver. A small amount is converted from estradiol, and even smaller amount may be actually secreted directly from the ovaries. There was actually done a preliminary, Meridian Valley Lab did a preliminary investigation on serum estrogens showing that the serum estriol was always higher than the sum of the estrone and the estradiol, or meaning the estrogen quotient, and it actually averaged 8.9. And this is even knowing that most of the estriol in circulation or in serum is the non-conjugated form, or is the non-conjugated form, excuse me. The study also showed the estriol levels fluctuated less than estradiol or estrone during the 28-day cycle. And what they concluded was that estriol may actually be the primary estrogen produced before menopause, but not estradiol. And there hasn't been actually any follow-up research to this, and hopefully, though, there will be. Here's a nice picture of the estrogen metabolism. Again, we'll go through that in more detail here. There are a lot of metabolites that we look at on the 24-hour urine profile. If you do the Comprehensive Plus hormone profile, the 2-hydroxyestrogens, both 2-hydroxyestrone and 2-hydroxyestradiol, are considered protective to the body or non-carcinogenic. The 16-alpha-hydroxyestrone is considered a carcinogen. The 2-methoxyestrogens, both the methoxyestradiol and the methoxyestrone, are considered protective, and then the 4-hydroxyestrone is considered a carcinogen. This is a great slide that I got from Dr. Wright that talks about some of this metabolism. So you see the androstenedione getting converted into estrone and then into all the other estrogens, whether it's estradiol, the 16-alpha, the 2-hydroxy, or the 4-hydroxy. And in the green, you see different nutrients or maybe even medications or environmental factors that will actually help to form those metabolites. And then if you see it in purple or a negative before, then you'll see that those products actually inhibit that formation. So for example, with the estrone going into the 2-hydroxyestrone, which is a favorable estrogen. The DIM, which is the extract from broccoli, or the indole 3-carbinol, which is also an extract from broccoli, exercise, flax, soy, and omega-3 fatty acids help with that conversion. And then the things that will help as well is if alcohol is removed from the diet, if pesticide exposure is removed or limited, and if a high-fat diet is removed and replaced with a lower-fat diet. And you can see that that would be true for the other metabolism, meaning the green being favorable and purple being negative. And then here's even further metabolism. So here we're looking at the methylation pathways, where we're taking the 2-hydroxyestrogens and turning them into the 2-methoxyestradiol. And the 2-methoxyestradiol are all very positive as well. So the green there, like the 2-hydroxyestrone turning into 2-methoxyestradiol or estrone, is the vitamin B12. And I specifically use the methylcobalamin. And then we have methionine, magnesium, folate, specifically methylfolate, or the 5-MTHF, betaine, SAMe, and zinc, all of our methyl donors. The 2:16 ratio is the 2-hydroxyestrogens divided by the 16-alpha-hydroxyestrone. This has more clinical significance with pre- or perimenopausal women, but it's hypothesized that the ratio is also important for postmenopausal women who are using the hormone replacement therapy. If a low level or ratio is found, this is associated with breast cancer, rheumatoid arthritis, lupus, and prostate cancer for men. And actually, sorry, the autoimmune disease would apply for men as well. The problem usually exists when the ratio is less than 1. Meaning that then you would be predisposed, or your patient would be predisposed to an increased risk of breast cancer, prostate cancer, or those autoimmune diseases. But there's also possibly a problem if elevated level do occur. There's one study that shows a correlation with an elevated 2:16 ratio being associated with a lower bone density, and actually a low 2:16 ratio being associated with a better bone density. So definitely something to take into consideration. So if you ever have a patient have a high 2:16 ratio, definitely something to follow up with, meaning maybe doing an NTX test to find out how much bone loss is occurring in the urine, or doing a bone density scan if it seems appropriate. The 2-methoxyestradiol has been really well studied. It's a potent apoptotic, well, it has potent apoptotic activity against rapidly growing tumor cells. It has anti-angiogenic activity through a direct apoptotic effect on endothelial cells. It causes microtubule stabilization by inhibition of the colchicine binding site. It's cardioprotective even by inhibiting vascular smooth muscle, cell growth in arteries. It has a 500 and 3,200-fold lower affinity than that of estradiol for estrogen receptors alpha and beta respectively. And the anti-proliferative activities of the 2-methoxyestradiol do not require estrogen receptors, which is just amazing, and are not influenced by estrogen receptor antagonists or agonists. And that should say at the very bottom that many different cell lines, in addition to breast and prostate, are inhibited. So really what I'm trying to say here is that making sure that your 2-methoxyestradiol level is at least mid-range or high normal is going to be very favorable as far as looking at cancer risk, not just breast or prostate cancer, but other cancers. And you can even treat with 2-methoxyestradiol. There are a couple compounding pharmacies that do have it. It is a little bit more expensive. The typical dose is usually about 200 micrograms, and I'll have that put with usually about 1 or 2 milligrams of estriol in 0.1 milliliter of cream, and have that applied daily, maybe days 1 through 25 of the month. If I have somebody who comes in that's really wanting to be preventative as far as breast cancer is concerned, if they have a strong history of breast cancer in their family, or we've had even some patients with previous history of breast cancer who want to use this. And in addition, even other types of cancers, like I just had a patient with acute myelogenous leukemia that came in, and we immediately put her on this 2-methoxyestradiol. So definitely a lot of good possibility. Besides, you can also, like we talked about earlier, use the methyl donors to be able to increase this level naturally. I did want to mention as well that some of these slides don't have references on them, but if you need references, I definitely do have them, and I'm happy to give them to you. So please do let me know by the end of the talk, or let Meridian Valley Lab know if you need any additional information on any of the information that I'm presenting here in the slides. Next, I wanted to talk about the 4-hydroxyestrone, which is considered a carcinogen. Most of the research here has been done by Dr. Cole Cavalieri, and I'm sorry if I'm pronouncing his name incorrectly, of the University of Nebraska. And while he believes that the 16-alpha-hydroxyestrone indeed promotes abnormally rapid cell growth and proliferation, it's not the cause of the underlying mutation in cellular DNA that initiates tumor cell formation. He actually reports that the 4-hydroxyestrone, when oxidized, can react directly with DNA, leaving a hole in the DNA that, if unrepaired, will initiate cancer. So high levels of the enzyme producing 4-hydroxyestrone are found in both benign and malignant breast tumors. And then known carcinogens from the environment can actually turn on the production of this 4-hydroxyestrone. In addition to implicating this mechanism in cancer of the breast, prostate, ovarian, endometrium, he says it has a role in brain and other cancers. So with this, we're wanting, again, to use methyl donors, and we're wanting to use DIM or other nutrients, as we talked about earlier, to shift production away from the 4-hydroxyestrone and to the 2-methoxyestrogens or 2-hydroxyestrone. And then actually there was another study I just wanted to bring up in hamsters that measured the ability of the estradiol, estrone, and their catechol-estrogens to induce DNA adducts. Neither the estradiol nor the estrone actually did induce DNA adducts at the concentrations listed. And the abilities of estrogens to induce the DNA adducts were ranked worse for the 4-hydroxyestrone. And the level of the DNA adducts induced by the catechol estrogens was markedly reduced by treatment with L-ascorbic acid. So not only are we looking at the pathways, but we're looking at how we can reduce this inflammation or the change in the cellular changes with vitamin C, something as simple as vitamin C. So definitely an encouragement to get all our patients to take some vitamin C. So here I'm just listing the optimal estrogen metabolites and what their levels should be. So for the favorable estrogens, we want them to be mid-range or high normal, and for the unfavorable, we want them to be low or low normal. Next, we'll talk about the progestogens, again, not to be confused with progestins. Progestins are the non-bioidentical progestins, and they aren't anything we ever see in nature. An example of this would be Provera. I don't recommend its use at all. Progesterone is produced by the ovary, brain, and placenta in pregnancy. And then in women, the progesterone levels are relatively low during the pre-ovulatory phase of the menstrual cycle, raise at ovulation, and are elevated during the luteal phase. And I do use that information when I am dosing that progesterone. I usually will use it with a menstruating female days 14 through 28. With a woman who's postmenopausal, I will still try to follow a natural cycle of the body, even if she's not menstruating, and do about the second half of the month or days 11 through 25. Sometimes I will do a biphasic prescription where I'll use 25 milligrams the first half of the cycle, like during the follicular phase, and then I'll bump it up to 50 or 75 milligrams during the second half of the cycle if people are really feeling like they need the progesterone almost all month long. Adult males actually have similar levels to those in women during the follicular phase of the menstrual cycle. And we do use progesterone occasionally with men, and that would be a great topic for further webinars. Progesterone is commonly manufactured from yam family Dioscorea. Dioscorea produces large amounts of a steroid called diosgenin, which then can be converted into progesterone in the lab. Progesterone has a number of physiological effects which are amplified in the presence of estrogen. Estrogen, through estrogen receptors, upregulates the expression of progesterone receptors. Elevated levels of progesterone potently reduce the sodium-retaining activity of aldosterone, resulting in natriuresis and a reduction in the extracellular fluid volume. So essentially, it's a diuretic. And then progesterone withdrawal is associated with a temporary increase in sodium retention due to the compensatory increase in aldosterone production, which combats the blockage of the mineralocorticoid receptor by the previously elevated level of progesterone. And I know that's a mouthful, but it's just helping to explain why some women do experience swelling or not have swelling with menses or with premenstrual changes and right after their period. So progesterone, as you can see here, like we talked about before, comes from cholesterol, then into pregnenolone, and then the progesterone can convert into the aldosterone, cortisol, pregnanediol. It can even convert into estrogen as well. Pregnanediol is the major progesterone metabolite. It is inactive progesterone metabolism, and it is measured in the urine really well. Urinary levels are an indirect measurement of progesterone levels in the body, and the values of progesterone are very well tracked by pregnanediol values in the urine. So actually the urine analysis doesn't look at actual progesterone. It looks at the pregnanediol, and we monitor our progesterone production or our exogenous progesterone use in patients with the pregnanediol level. The pregnenolone is the mother of all steroid hormones, as we saw with the flow chart. It's also a neurosteroid found in high concentrations in the central areas of the brain, certain areas in the brain, and is actually even synthesized there. The neurosteroids are neuroproductive and enhance myelinization. So we do use pregnenolone when women especially complain of memory problems. I won't use a lot of pregnenolone, as mentioned at the very bottom, because there's so many downstream metabolites of pregnenolone. We never know really what it's going to be converted into unless we're monitoring pretty closely. So I always start with 25 milligrams, and I do usually use it in a sublingual form, and I'll use it before bed just because it has the potential of converting into progesterone, which can be sedating. Pregnenolone and its sulfate ester are under investigation for their potential to improve cognition and memory function. And as you saw, or you heard me say, it can metabolize into a lot of other hormones as well. So sometimes people will be more comfortable just using pregnenolone and not using any of the other hormones, and that's just fine as long as you're monitoring their levels. The pregnanediol is metabolized indirectly from progesterone and pregnenolone, and elevations occur with congenital adrenal hyperplasia. And congenital adrenal hyperplasia can present in newborns, or it can present as an adult. There's different types, and that's something that we would see with the labs. When a child is born, there's a lot of symptoms that the child would present with that would indicate to a doctor that this child has a problem with congenital adrenal hyperplasia. I won't go into that actually in detail today, but I just wanted to let you know that the pregnanediol on the urine test, if it does come back high, is an indication of this congenital adrenal hyperplasia. And the biggest thing that we're concerned about with our patients, our adult patients, when we're looking at this, is that a lot of times it will prevent the production of enough cortisol and cortisone. So those patients will actually have to use replacement hydrocortisone. So now our androgens. First, testosterone, produced in the adrenals, ovaries, liver, skin, and brain. And on average, an adult human male body produces about 40 to 60 times more testosterone than an adult female body. It does get metabolized to estrogen, DHT or dihydrotestosterone, androstenediol, androsterone, and etiocholanolone. And in 1889, a Harvard professor self-injected himself subcutaneously with a rejuvenating elixir consisting of an extract of dog and guinea pig testicle. He reported at that time in The Lancet that his vigor and feeling of well-being were markedly restored, but predictably the effects were transient. And then that initiated more research into testosterone. So this is some of the early types of hormone replacement therapy that were done by people. And there's other stories that are very similar to this. So the testosterone conversion, you can see it can go into the estradiol or the dihydrotestosterone, either the 5-alpha or the 5-beta. And again, the Meridian Valley Lab testing for testosterone metabolites that you can get through serum now does talk about this in a lot more detail than what can be obtained through urine. And on this slide, there's different enzymes that you can see. There's aromatase, 5-alpha reductase, and 5-beta reductase. And then there's the different hormones or nutrients or other molecules, medications that are listed either in the green for being positive or purple for being negative that influence the production of these downstream metabolites. And I will talk about the enzymes in more detail in just a little bit. DHEA is produced in the adrenal glands. The levels peak around 25 to 30 years of age and decline thereafter. It's converted to androstenedione as an intermediate metabolite and may become testosterone and its metabolites or estrone and thus other estrogens. It's the most abundant steroid in healthy persons. It's very powerful in its action in autoimmune disease. One of my colleagues, Dr. Wendy Ellis, who works at the Tahoma Clinic, she did a whole presentation on DHEA in autoimmune diseases, and it was fantastic. There are just so many studies in how powerful the DHEA can be in helping people who have different types of autoimmune disease. So definitely something to think about, not necessarily for just people who are going through the changes of life as they're getting older, but if there is a certain autoimmune disease, it can be very helpful. A nice flow chart about DHEA, first coming from the pregnenolone to the DHEA and then downstream to the androstenedione, which then can be converted into the testosterone or estrone or etiocholanolone and androsterone. And again, here, Dr. Wright's done a great job of putting in green things that are helpful in those conversions, or in purple things that will negatively affect those conversions. Androsterone was mentioned earlier. It's a terminal androgen metabolite. It's useful in monitoring testosterone therapy. It's converted from androstenedione by the enzyme 5-alpha reductase. And then the etiocholanolone, as mentioned earlier, is also a terminal androgen metabolite. It's useful in monitoring DHEA supplementation especially. It's converted from androstenedione by the enzyme 5-beta reductase. And then the dihydrotestosterone, it's 10 times more powerful than testosterone. It cannot be aromatized to estradiol like testosterone. And again, another plug for the test that Meridian Valley Lab does on the testosterone metabolites. We actually cannot see the dihydrotestosterone at this point in the urine. So we do have to look at it in the serum. And the testing that's done on that is done by the LCMS method that I was talking about at the very beginning of the presentation. And it's an extremely useful test for especially men who may be predisposed to prostate cancer or whose metabolism testosterone seems to be altered in some fashion. So now on to corticosteroids. First we have cortisol, which is a major glucocorticoid. It's a weak mineralocorticoid as well. It's the second most plentiful steroid in a healthy person. It's interconverted to cortisone by the enzyme 11-beta hydroxysteroid dehydrogenase. It binds with mineralocorticoid receptors with the same affinity as aldosterone. The normal ratio with cortisone is about 0.7 to 1, and this is something that you'll see on the urine test. It'll give you the ratio. And the reason why you're looking for this is because the cortisone should actually be the predominant glucocorticoid activity, and that's because the cortisone doesn't have any mineralocorticoid activity. If the cortisol does exceed the cortisone, or the ratio is altered or elevated, then there may be something called apparent mineralocorticoid excess. And with this, you can get high blood pressure. So you can treat to get this conversion to change so that the cortisone is higher. And actually there's a slide in a little bit where we will see that and what we can do to change it. I won't again go into a lot of detail about this apparent mineralocorticoid excess, but just so you know, it is something that could show up on the 24-hour urine test. However, it doesn't show up very often. Then we have cortisone, which was just mentioned previously. It is a glucocorticoid just like cortisol, but it's the inactive form of cortisol, and it's interconverted to cortisol by the 11-beta hydroxysteroid dehydrogenase. So here's the slide I was mentioning that we would come to, where you can see the cortisol and the cortisone getting interconverted based on what enzyme you're looking at, either the 11-beta HSD1 or 2. So to get cortisol to go back to cortisone so that you have that ratio that's closer to 0.7, testosterone is actually something that can be really helpful. And if you're using any licorice, that can be helpful to remove. And then we also have a flow chart there showing that cholesterol going to pregnenolone eventually gets into cortisol, and then showing all of its metabolites. So you have different metabolites that you're going to be seeing on the 24-hour urine test, and this is really helpful in assessing a person's daily production of cortisol and cortisone, in the sense that we're using this test to address people who have chronic fatigue, or maybe are having trouble with weight, but definitely more often looking at why somebody's feeling so tired. The tetrahydrocortisone, tetrahydrocortisol, and allotetrahydrocortisol are all terminal metabolites, and they reflect about 50% of the daily cortisone synthesis. When you add those three together, the values should fall somewhere between 5,000 to 7,500 micrograms for women, and 7,500 to 10,000 micrograms for men, to mean that they're having adequate cortisone production. What you may see is that for people who have hypoadrenal or adrenal fatigue, that they will actually show up with these low terminal cortisol metabolites before the cortisol and cortisone start to decrease or become suboptimal. So for somebody maybe you thought had adrenal fatigue but wasn't showing up on a blood test or a saliva test, if you do this test with all the other metabolites that you're able to measure, you can get a bigger overall picture or better indication of what's happening in the adrenal glands. And again, here it gives you that calculation of how you can decide how much a person's making on a daily basis. So you take those three and add them up, and that gives you about half of the total daily production of cortisol. So for example, if you add them up and it comes to 5,000 micrograms or 5 milligrams, then the body's making about 10 milligrams a day, which would be okay for a woman, but it's still on the low end of the normal range of what you would want. This is another slide just showing the conversion. It's nice to reference. And this is just an example of one of the hormone reports. What I wanted to specifically point out here is what I'm talking about, the addition of the metabolites. So about 2/3 of the way down, right underneath cortisol, the hormone tetrahydrocortisone is listed. It's 1,143. That's low. The allotetrahydrocortisol is 1,197, which is okay. And then the tetrahydrocortisol is 636, which is low. But more importantly, what we do here is we take those three numbers and we add them together. So below, you can see the sum there is 2,976 micrograms, and I just rounded up to be about 3 milligrams. So that's going to be half of the daily cortisone production. So the body's only making about 6 milligrams. And this is a female, so this is definitely a low level of cortisol. And the cortisol, you can see, came back at 44, which is not quite low yet, but definitely this person is showing the need for adrenal support, if not maybe a little bit of hydrocortisone. There's other cortisol metabolites that will show up on the 24-hour urine test. There's 11-beta-hydroxyandrosterone and 11-beta-hydroxyetioplanolone. They're both terminal metabolites. Another glucocorticoid showing on the test is 11-dehydrotetrahydrocorticosterone. It's inactive. It's a metabolite of corticosterone. Compared to cortisol, corticosterone has approximately 1/3 the anti-inflammatory action, but 15 times the sodium retaining action. So if you see that come back high, that might be one of the reasons why your patient is actually retaining water. And by treating the adrenal glands, helping that level to come down, then the person's water retention should actually decrease as well. Aldosterone is a major mineralocorticoid produced by the zona glomerulosa of the adrenal cortex, and it acts on the distal tubules and collecting ducts of the kidney to increase the reabsorption of sodium and water and secrete potassium in the kidneys. The medication spironolactone lowers blood pressure by blocking the aldosterone receptor, and it also can treat hirsutism due to its anti-androgen effect. The aldosterone is a metabolite of corticosterone, and low levels may actually be associated with autoimmune hearing loss. We've had ongoing studies here done with Dr. Jonathan Wright and Dr. Lauren Russell in using aldosterone through a compounding pharmacy for treating autoimmune hearing loss and have seen good success with it. There's also metabolites of aldosterone that are sensitive markers for monitoring acute adrenal stress and can be the first to rise in a cortisone stim test, meaning the test where ACTH is given and the cortisol is measured before and after. The aldosterone metabolites are there, the allo-tetrahydrocorticosterone and tetrahydrocorticosterone. And then we have some other hormones. First, growth hormone. So here we have the anterior pituitary that's been stimulated by the hypothalamus. And as a result, growth hormone will stimulate the production of growth factors, which can help muscle, can help bone, cartilage, kidneys, skin, and cellular repair and regeneration, as well as reduce adipose tissue if it's in a high enough level. So in the urine, you're getting a 24-hour urine for growth hormone. So you're getting the average of all the peaks and flows of the growth hormone, which is great because we know that it mainly peaks at night. Deficiency symptoms you probably know already: short stature in children. In adults, you can see exercise intolerance, lower strength, increased body fat, glucose intolerance, dyslipidemia, fragility of skin and blood vessels, and lowered immune function. And this is just an example of how it'll be reported on the hormone test. This person's level is within range, but on the low end of the normal range. And then with the growth hormone, you can stimulate production with all of these nice things that are being listed there for you, whether it's amino acids or exercise, different types of exercise, adequate protein intake, deep sleep. But then it also can be produced by stimulating with different hormones such as testosterone, estrogen, specifically estradiol, progesterone, thyroid, melatonin, even HCG or human chorionic gonadotrophin, which you hear about mostly for weight loss, but it's also something can be used to stimulate growth hormone, as well as secretagogues, which are primarily different combinations of amino acids. And then there's different things that will decrease growth hormone as listed there, which are pretty much just the opposite of what's listed above. The thyroid hormones actually can be measured in the urine as well, both the T3 and T4. And as you know, it's helping to assess metabolism in the body, or speed of protein synthesis, energy use, and also helpful because they help with sensitivity to other hormones. You can see here that tyrosine and iodine may be used to help with the T4 and T3 production, and the T4 is the more stable form, but the T3 is actually the more active form. And the T4 to T3 conversion happens within the cells, whereas the T4 is produced in the thyroid. So here's an example of the report where you're seeing the free form of both the T3 and T4 in the urine. The T3 was low here, with the T4 being within range but low normal. One of the things we know we can do to help with the conversion of T4 to T3 is add selenium. And these are some nuts to help with the conversion of the T4 to the T3. This is a great slide that Dr. Wright had made, and I'm sorry, those were Brazil nuts, that talks about Andrology 101. Testosterone metabolism. And here I'm just being more specific because we're going to go into the enzymes and how those help with the hormone metabolism. We have the testosterone that's getting converted by the 5-alpha reductase into the dihydrotestosterone, and then we get the testosterone converted by aromatase into estradiol, and then you can see it can get hydroxylated or go into the androsterone and etiocholanolone. And there is on the urine test an enzyme activity phenotype assessment that will look at the 5-alpha reductase enzyme to tell you exactly where your patient falls as far as how active that 5-alpha reductase enzyme is. And below you can see that very low activity, it can occur in men taking finasteride, a 5-alpha reductase inhibitor. You typically want the 5-alpha reductase activity to be found mid-range. High levels can be found in men with BPH. It's also associated with insulin resistance and premature baldness. And I shouldn't say this is just something we look at in men. We definitely do look at this in women, but it tends to be something that comes up as more of an issue in men. So more specifically, the aromatase, that is induced by cortisol, zinc deficiency, vitamin C deficiency, poor vegetable consumption, low T3, insulin, growth hormone, and pro-inflammatory cytokines. It's widely distributed in all tissues, and it converts testosterone to estradiol as well as androstenedione to estrone. It may be up or down regulated by different plasticizers like bisphenol A or phthalates. So here's an example of a man, 50-year-old, who has overactive aromatase enzyme. So with the estrogens, you can see that the estrone came back high at 10.7. And then on the next page, we'll look at here the first hormone that came back low is the testosterone, and it's 12.1. And the reason for this is because it's getting converted too much into the estrogen by, or estrone specifically, by the aromatase enzyme. And then we have the 5-alpha reductase enzyme that converts the androstenedione to androsterone, and it converts testosterone into DHT. It also does work with the glucocorticoids as well. It converts cortisol into allotetrahydrocortisol, and it converts corticosterone into allotetrahydrocorticosterone. Elevated activity is associated with metabolic syndrome and hypothyroidism. The effects of the increased 5-alpha reductase activity we talked about before, hirsutism and hair loss, but also acne. It's inhibited by zinc, GLA, saw palmetto, and progesterone. So this is one of the reasons why we do use progesterone in men. And the enzyme is present predominantly in the scalp and in the prostate. So here's an example of somebody who has an elevated 5-alpha reductase enzyme. So the testosterone is low. I don't have the page on the estrogens, but I can just tell you that the estrogens were just fine. So we know that the reason for the low testosterone wasn't because of an overactive aromatase enzyme. But then if we look at this next page, what we see is that the 5-alpha reductase enzyme activity is very high. The ratio of 1.6 for the androsterone to etiocholanolone and 2.12 for the allotetrahydrocortisol are both very high. So this person we'd want to evaluate for insulin resistance and treat accordingly, as well as add in some zinc, some GLA, and maybe some saw palmetto. And then we have the 11-beta hydroxysteroid dehydrogenase enzyme. These enzymes are the ones that convert between cortisol and cortisone. There's the type 1 and the type 2 that we talked about previously. Again, the slide that I did show you previously as well. And lastly, here I'm just saying that with this quote that things are different now. We find that women are getting pregnant when they are older, which is wonderful for them. However, the hormone levels are starting to decrease. So I thought Irma Bombeck did a great job of summarizing this. She says, I'm trying very hard to understand this generation. They have adjusted the timetable for childbearing so that menopause and teaching a 16-year-old how to drive a car will occur in the same week. So it's definitely a challenging area as far as helping a woman or a man to balance hormones, but in the end, very successful for most people and very safe as well, especially with the 24-hour urine testing to help monitor all the metabolism and the levels of the different hormones that you're using. So as I mentioned, there are definitely additional references available upon request, and you can reach me through the clinic. I have listed the number there. We also have doctors on staff at Meridian Valley Lab that when you order urine testing will do interpretations for you at no charge. So you just have to call and make an appointment for that. Sometimes you can call at the last minute if your patient is there, but we do encourage you to make an appointment ahead of time if possible. So I'll open this time up. We have a few more minutes if there's any last questions. Otherwise, I thank you very much for your time, and if you have any other questions, definitely give me a call if you're not asking currently. I just wanted to make a last mention. There hasn't been any questions proposed yet, but for everybody who did sign up today, there is going to be a complimentary 24-hour urine test that you can get for your time, and hopefully that will be really helpful in being able to learn more about what we talked about today. I know when you do it firsthand, it makes a big difference rather than just listening or looking at what we're talking about today. So thank you again for your time, and I'm definitely available by phone for any further questions. So there is a question actually that's coming in now that says, is there a timing for growth hormone as in start with some other hormones and proceed to growth hormone per Dr. Hirtogi? So what I usually do, and hopefully I'm answering the question the way that you're asking, is that I won't start growth hormone immediately for patients. If it comes back showing low or low normal, I will take that into consideration and I'll treat the other hormonal deficiencies first. So I'll make sure that the thyroid is optimal. I will make sure that the testosterone level is optimal, the DHEA level is optimal, that we get the women to have enough estrogen. I'll make sure that they are abiding by a higher quality protein-dense diet and getting enough exercise, all to help stimulate the growth hormone production, as well as maybe even looking at amino acid deficiencies and treating with any amino acid deficiencies that might be low. And I tend to use more of the glutamine and the glycine, which is in Dr. Hirtogi's protocols, along with exercise, meaning to take about 3 grams of each of those amino acids before exercise or before bed to help stimulate growth hormone. I do get mixed results. And then if we do a retest and the growth hormone just really hasn't come up as much as we'd like it to, then at that point, if the patient's interested, we'll have a conversation about starting growth hormone. And I actually do follow Dr. Hirtogi's protocols on looking for weak adrenals and using more conservative dosing if the person has weak adrenals, but it is something that I will use that I will use. And then the question is coming up, in what form do I use growth hormone? And I do use the injectable form. I'll use the sub-Q injectable form through either the compounding pharmacy or regular pharmacy. And then last, we have another question wanting to know if the webinar will be posted online, and the answer is yes, it'll definitely be posted online, so you'll be able to access the slides and review any of the information as needed. And the webinar has been recorded, so I believe that the presentation will be matched to my voice so that you can listen again if you would like. So I'll just wait to see if there's any last questions. We are at the end of our time. Again, I really appreciate that you took your lunch time today to listen. Hopefully you were all able to sit and relax and have a good nutritious lunch while you were listening to this wonderful world of hormones. And I will definitely take any further questions from you via phone call if you have any further questions. And actually, if you wanted to use email as well, my email address is cm, as in Michelle Hinchcliffe, at yahoo.com. That would be fine as well. Thank you very much, and I hope you all have a great afternoon.